All right, guys, thanks for coming. We're going to get started now. So just bring the slides up. Can everyone see the slides? Can someone just confirm?
Yeah, we can.
Yeah.
You can. Okay, wonderful. Okay, so yeah, again, thank you for everyone that turned up. Thank you for the those of you that came in person as well. Appreciate it. So yeah, this is our first session of hopefully many, but we've got five planned for you this year. And the first one is the road to consultancy, as you can see. So essentially, this is going to be about the structure of surgical training and also sort of how to navigate that because there's a lot of information out there. Our job for you is just to condense that and I give it to you in more of a digestible form. So who are we? So I'm Andras, I'm the session lead, and then this is Ardil. Hello. So he's the co-lead as well for this year. And we're going to be holding all of the sessions, apart from potentially the last one, where we're going to get a core surgical trainee in, and he can answer some of our questions. Okay, so this is a feedback form, so feel free to scan that now. But obviously you can't, finish it until the end, but just hold on to it. And if you have anything in mind that comes to you, then fill that in during the session. All right. So as I said, we've hopefully got five of these sessions planned for you throughout the year. So the first two is more to do with the sort of structure of surgical training, how to maximize your surgical training points at university. And then session three and four is a bit more technical. So we're going to take you guys through how to do a systematic review first, and then hopefully bits and quips as well. And the idea behind that is it's quite a difficult thing to get these, but you need to get them for your portfolio. And we thought it would be good to have a session on each of them. And then lastly, we'll try and get a day in the life of a surgical trainee. One of our friends is going to come in and talk to you guys. All right. So I've said OpSurg a lot. What actually are we? What do we do? So we're not RUMS affiliated. We are generally just an organization that we've formed, and it's operation surgery. So the whole point is we're aiming to bridge the gap between pupils and medical students to get into surgical careers. So the idea behind it is we saw that there's a lot of mismatch, especially in the surgical field, between people who are surgeons, they tend to be more from specific backgrounds, like privately educated. And unfortunately, when we go into schools, we hold talks, and we often find that people kind of put off doing medicine and sort of they never even think about surgery in general. So we thought one of the ways we can combat that is to do outreach talks, and another way we can do that is to target medical students and try and persuade them to do surgery as well. So that's what we're doing now.
Right. So in this session, we're aiming to firstly condense all of the information out there, make you aware of the different timelines of surgical training in the UK, including run-through and uncoupled pathways. Also, we want to introduce you to the portfolio requirements for core surgical training, and we'll go into that in a lot more detail in our second talk. So, as many of you know, the competition ratios for postgraduate training is worrying for both surgery and medicine. For the most recent year of core surgical training applications, it was for every 10 applicants, one person successfully got in. And as you can see, over the last 3 years, the ratios have got worse and worse. This is why we've created these sessions, hopefully to provide some information and advice to make it to the next step of your surgical career, and to give you somewhere to start as well.
Okay, so in order to kind of get into surgery, we need to know the two specific routes into surgery. So these are the uncoupled surgical route and the run-through surgical route. So uncoupled is the kind of the more common one. So most of you guys who end up doing surgery will end up doing the uncoupled route. So this is core surgical training one that you apply to outside or just after foundation year two. And you're in core surgical training for 2 years. And then there's a reapplication phase, and then you apply for ST3 or specialist training part three. And then after that, you do all of those the rest of the years up until ST8, where you sit a consultancy exam and hopefully become a consultant. Now, there's also a second type, so run through. This is three specialties. So we'll talk about that a little bit later. But essentially, you apply for ST1 straight after foundation year two, and then you do 8 consecutive years with no reapplication. And then just to kind of put it into perspective, this is how that would look. So you can see that that ST3 reapplication phase is only relevant for the uncoupled route, whereas run through, although slightly harder to get into, is you have that peace of mind where once you're in, you're essentially beelining it to consultancy. So, as I said, most specialties are uncoupled. So, essentially, all specialties are uncoupled apart from neurosurgery, cardiothoracics, and then max facs as well. So, it requires you to do those initial 2 years first. And just to illustrate, these are the specialties. So, I know there's a lot of keen orthopods and people who like doing general surgery as well. It's quite popular to do plastics as well. So, if any of you in this chat want to do that, then this will be your direction that you'll take. So there are considerations for both types. Let's talk about the uncoupled route first. So there's lower initial competition ratios. As we mentioned, they're around 8.5 is the competition ratio. And there's naturally, because there's far more positions, because it's the standard entry. And there's one of the big benefits of this is that you don't really need to commit to a specialty per se until you reapply for that ST3 position. Which is, you have 2 years of really rigorous medical training or surgical training as well. And then that can help you make that decision. But with everything, there's drawbacks too. So getting a spot on CST is great, but it doesn't actually guarantee you a spot for ST3. So you could train for 2 years, you could get very technical with surgery, but unfortunately, it's very difficult to find that ST3 position. And exactly, kind of illustrating that point again is you need to apply twice. And if you're someone who gets quite stressed out because of that, that might be difficult for you. And the bottleneck for ST3 is actually slightly worse than CST. So just to illustrate it, there are about 645 core surgical trainee 2 positions in 2024. And there were only about 400 ST3 positions for that same year. So this means that around 60 to 70% of CST graduates find a direct ST3 position, but the remaining do not, unfortunately. So don't worry about this too much though. So after you finish core surgical training and you're looking for an ST3 position, you're incredibly employable and you're already very highly skilled. So this means that a lot of CST graduates use that time to kind of get their surgical cases up, to strengthen their portfolios. And there's also a job title that you can get. It's called a trust grade surgical position, where you're essentially filling in for surgical gaps in various trusts in the NHS. It pays a lot better than F1 and F2, as well as CST1 and CST2. And you can really find and hone your skills in your specific specialty. So there's lots to do after core surgical training. All right, now getting on to run through. So this is the one where we say you apply for surgical training 1 or specialist training 1, sorry, and then you get all the way to the end with no reapplication. I mentioned it's only 3 specialties. There's neurosurgery, cardiothoracics, and it's notoriously high competition ratios for that because of the limited spaces. And then finally, there's oral and maxillofacial surgery as well. So even more considerations. One of the biggest things that people like about run-through specialties is once you're in, and you're guaranteed, given that you pass each year, you're guaranteed that 8 years of training. And there's no need to sit kind of supplementary examinations that you would otherwise need to do to specialize as well. But the portfolio requirements are quite general for core surgical training, but they're more specific for run-through training. And as you can see, the competition ratios are anything but pretty. So especially for cardiothoracics, 73.7 is quite wild. It's quite crazy for neurosurgery as well. Oral and max facs is a lot better, but it's the only surgical specialty which requires you to do a medicine degree and a dental degree as well. Usually what that means if you're a UCL is that 6 years of medical training, and then you have another at least 3 or 4 years. You can do an accelerated dental course. But that means, at least 9 or 10 years in training. So at university, which if it's your cup of tea, that's great. But, some people are put off by that. And I think it goes without saying that we've talked a lot about competition ratios and, numbers and percentages. And unfortunately, as much as you do need to consider that and you need to consider sort of what you're likely to get and apply tactically, it shouldn't be the be all and end all. It's really a shame that, the world of specialist training is such a way that we feel that we have to choose based on these competition ratios and we kind of get bogged down by the numbers. But ultimately, it's something you're going to be doing for most of your career. So you need to enjoy it at least a lot, right? You can have some bad days, but you need to love what you do. So just back yourself. And even if the competition ratios are 73.7, like they are for cardiothoracic surgery, if that's what you really want to do, I would focus on building your portfolio rather than thinking about ways you can put yourself off because it's just so competitive.
So let's talk about now applying for core surgical training. So previously we've spoken about a surgical portfolio, but let's give a bit more information on that. In essence, it's basically your CV to get into surgical training, and the domains are as follows. So firstly, commitment to specialty, teaching experience, publications and presentations, and quality improvement projects and audits. So the reason why this is important to talk about this is because it makes up a proportion of your CST interview, where the assessors will look at your work or your experience in each domain and grade you from A to E. And ideally, you would want to max out your points or grades in this section, as it's something that you can work on whilst in medical school and in foundation years as well. And a lot of the advice we're going to give now is more specific to core surgical training. So commitment to specialty is split up into operative experience and surgical experience. Surgical experience looks at the time that you've spent in surgery outside of medical school and foundation training. And the two ways that you can do that are through a taster week. So that's at least 5 days of clinical work experience in a surgical department of your choice, something that you can do in medical school, and also you can do this in your foundation training as well. And then you can also get maximum points in this specific area if you do a 4-week surgical elective as well. Next, we've got operative experience, which is looking at basically the time that you spend in theatre, in particularly assisting or scrubbing in and then assisting in procedures. And the way that you record this is via an e-logbook. We'll talk more in detail about this in our next session. But whilst you're in surgery, it's important to note down these specific things, as these are the things that you need to write into your logbook when you're adding an operation. And there's our founder. Okay, so next we've got teaching experience. And, arguably the easiest way to do this is by being involved in a society, in particular being the education sec, although it's not required. I think being part of a society provides you a platform to give teaching and also advertise a teaching. So it is very helpful to do that. And there's a range of ways you can do that, specifically whilst you're at university. As you can tell, we've got Surgical Society, Medical Society, and UCL teaching things as part of RUMS where you can do this. And within these, there are subspecialties as well. So there's a lot of opportunity. Whilst doing your teaching, it's important to have feedback forms, which you can do via Google Forms or Qualtrics, which is what we're using, just so you have evidence when going to the consultant who's going to sign you off, so they can see that people have gone to these sessions and also learned things from your sessions. I'd also say, ideally, you would go to a consultant before you deliver the teaching series, just to show them a plan, the ILOs, so they can be on board with your series from the start. And usually to get maximum points, you need to work with local educators, deliver four sessions of the teaching and be in person as well. At the moment, we're doing a hybrid sort of session, which also works. Next, we've got publications and presentations, which is usually, notoriously the hardest thing to get maximum grades or points in. But we'll just give a quick overview of what would get you maximum points. So firstly, you can either do it through the publication route by being a first author in a PubMed cited publication. Generally, the journal doesn't matter, like it doesn't have to be Nature, but it should be PubMed indexed. The other way that you can get maximum points is by placing first an oral podium presentation at a national or international conference. And in our next talk, we'll talk more about how to get involved with research and how to find yourself presenting at conferences as well. Next, we've got quality improvement projects and audit projects as well. And they're both ways of assessing current practice and whether or how it can be improved. A quality improvement project focuses on making changes on an area of care using cycles of change and assessment. And on the other hand, an audit measures current practice against a defined standard or clinical guidelines, and it focuses usually on your department's compliance with these. I'll say that you do have an opportunity. Well, everyone in F1 has to complete a quality improvement project where they'll have to lead it. But I would recommend getting involved with this at medical school as well, where you may not be leading your own project, but you will be part of the team. And I think doing this gives you the opportunity to see how one is ran from start to end, and put you in a better place when it comes to leading your own project. Here, this is a long slide. I'm not going to go through it fully, but what person specification is, it's basically guidelines for us, it's a standardized description of what qualities, behaviors, and skills and qualifications are required for someone to enter surgical training. I think it's useful to have a look at this as a prospective surgeon just to see what's required. And it also shows you what the assessors are going to be looking at when picking someone to go into surgical training.
Okay, guys, so we mentioned the MSRA earlier. So this is essentially, you can see it stands for the Multi-Specialty Recruitment Assessment, and it's the generic exam that you need to do whether you want to go into a surgical specialty or a medical specialty. So it's a two-part exam, usually sat in the autumn of either F1 or F2. Most people choose to do it in F2 purely because you just have more time to revise. It's in January this year. And there's also another intake in February. But essentially, scoring highly on the MSRA kind of guarantees you a CST interview if your portfolio is up to scratch. So this is kind of that last hurdle that you do before you actually get the interview phase. And it's comprised of two parts. So there's part A, which we'll go into in more detail, and part B. And it's online. So you do it a little bit like the UCAT in a test center. So hopefully you don't get PTSD flashbacks from doing the UCAT. Fingers crossed. All right, so part A, professional dilemmas, it's really just a fancy way of saying it's a situational judgment test. So they look for four main, what they call domains of competency. So these are your professional integrity, your coping or your ability to cope under pressure, your ability to manage other people in a team setting, and kind of your experience with teamwork. And then finally, your communication skills. So as you know, a lot of us have already done an SJT exam or something similar. It really is just they give you a scenario and then you have to rank responses based on how appropriate they are or how relevant they would be for the situation. And this is 40%. So part A is 40%, part B is the remaining 60%. However, from what we've heard anecdotally from sort of CST trainees, is that this is actually a bigger kind of differentiator compared to part B, because part B is sort of clinical knowledge. So most people that do this exam are actually quite good at that already. So the situational judgment test is what kind of discerns good marks from great marks. So it's not to be slept on. There's loads of question banks out there just for the MSRA in general. QuesMed have a really good one. I believe PassMed has one too. But yeah, so most people say just revise for about 3 months beforehand and you should be fine. So I've got an example question here for you. Is anyone brave enough to turn their mic on and have a go at this? Or you can put your messages in the chat if you feel that's better. Uday, can you monitor the chat just in case, because I can't see it?
Yeah, we have no takers right now.
No takers.
The crowd.
Anyone want to have a go? No? Okay, never mind. All right, not a problem. So essentially, you see some of these options are obviously not the right answer or not the best or the most appropriate answer. So the guidance is try and get the most appropriate, try and get the least appropriate, and then you can mess around with the ones in the middle. But it looks like this. So yeah, again, they're looking for whether you have the empathy to deal with quite a rough situation. Situations like this happen, unfortunately, quite common, quite often. So yeah, they're just looking at whether you can hold your own in that environment. Now, we mentioned part B is clinical problem solving. So it's an SBA question format. And as I mentioned, this isn't just for surgery. So this is medical too. So expect to be tested on everything, a little bit like your PassMed. And it's similar to the UKMLA. However, anecdotally, it's a little bit harder. So naturally, people are being tested in their F1, F2 years. So it will be slightly more difficult. And again, it makes up about 60%. So this slide is to do with sort of the relationship between run-through specialties and MSRA. So some run-through specialties use the MSRA, some don't. So neurosurgery actually does use the MSRA. Cardiothoracics has a loose relationship with it. But often what we find is that run-through specialties um, tend to have their own specific way of assessing how good you are. And that includes SJTs during interviews and also sort of situational awareness tests as well. A lot of people have said that when they do their sort of neurosurgery interview or their cardiothoracics interview, it can feel a little bit like an Oxbridge interview. So it's like a panel where they really test if you can do clinical scenarios under pressure. And you're probably thinking, if they don't use the MSRA, what do they do instead? So we mentioned that their portfolio requirements are quite rigorous. So this is just an example that we've pulled from the most recent neurosurgery guidelines. They actually want to see that you're committed to the specialty really early on. So they look for early commitment, which is why they give you scoring points for undergraduate research as well as undergraduate electives and surgical attachments as well. There's one thing for neurosurgery that I believe no other specialty has, and that's your practical and psychomotor skills. So this refers to surgical courses that you could have done to a high level, or any practical skills training that you've done to a high level, and that needs to be certified and signed off. But it can also include sort of national or international achievements in either sports or fine arts. So they just want to see if you have the manual dexterity to become a neurosurgeon, which makes sense. All right, moving on to interviews.
So let's give a quick bit of a timeline. So before you sit your MSRA, everyone's going to apply for core surgical training via Oriel, which is the platform that you'll become very well, you know a lot about it when you're applying to your foundation year placements. So after you've applied, then you'll sit your MSRA, and then depending on your score, then you'll be offered an interview place. So from the most recent year, there were just over 1,000 interviewees who for 630 posts. And the interviews are held a couple months after sitting the MSRA as well. So into the structure, so split into two main sections, so two 15-minute stations. And the first one is a management and clinical station, where you'll firstly have a 5-minute management scenario, which is kind of SJT style. So it's assessing non-clinical dilemmas, looking at professional and ethical behavior, patient safety, and also leadership. Following that, you'll get two clinical scenarios assessing basically your care of an acutely unwell patient, and it will use you'll use your A to E structure, but also take principles from ATLS or CCRISP, which is care of the care of the critically unwell surgical patient as well. Following that, you'll have your portfolio station, where you'll firstly have a pre-prepared 3-minute leadership speech, which you will learn by yourself beforehand, and then you'll be questioned on that after. Following that, you will have 2 5-minute questions on 2 of your portfolio domains. Also, during the interview, the assessors will have up to 10 minutes to review your portfolio and then grade it by themselves after you previously would have submitted it in. So let's talk about going into higher surgical training from SC3 onwards. It's important to know that portfolios and exams don't stop. So in terms of your portfolio, you'll be required to keep a logbook, which is looking at the cases that you've been involved in, so surgical logbook, courses that you've been involved with, like ATLS, and then also being involved with further audits and QIPs. You'll also need to sit your MRCS exam, which is split into 2 main bits. So the first section, part A, you'll have 2 SBA papers. And then in the second section, part B, there'll be OSCE related as well. And then in terms of what happens next, so say you've got into your higher surgical training, so SC3 onwards, these are the things that you'd expect before becoming a consultant in the future. So firstly, you'll have your annual progression checks, which once again, will look at your operative experience, how you're transitioning from assisting to then hopefully leading surgeries as well. And then you'll have your workplace-based assessments similar to our SLEs at UCL, and then your involvement in teaching, research, audits, quips, leadership, etc. Prior to becoming a consultant as well, you also need to sit your next exam, which is the FRCS, which is split into two parts similarly like the MRCS, except in the SBA section, so section 1, there'll be questions that are more specific to the specialty that you're in rather than the whole of surgery. And then in the second section, it will be a couple days of oral vivas as well. And you'll be examined to the level of a consultant. And it's important to know that FRCS has to be completed before you are awarded your certification of completion of training. Then you'll also have the opportunity to complete a fellowship, which is where you can gain highly specialized expertise in kind of a niche area of surgery. And it's usually done a year before you apply for consultant posts. But it kind of just gives you your unique selling points as someone who's going to join a department. And then you'll have your interview where similarly, it's kind of like a job interview where there'll be a panel interview for a consultant post at a specific surgical unit. And you'll be assessed on quite a few things, but basically they want to see whether you have the competencies to join as a day one consultant. They'll be looking at your readiness for independent practice in theatre, your leadership skills, management, and also whether you'll be a good fit for the team as well. And then hopefully you'd have made it.
All right, guys. So that's essentially what we've got for you today. So as you can see, it's a really long and winding road to get to consultancy, especially through that surgical route. But I think if you're joining this, you're clearly keen already. And it's nice to see that we've had a lot of signups from lower years as well. So you're thinking about your portfolio even in sort of first and second year. Yeah, which is really good. So yeah, a little message from the team. So this is our founder, Uday, and Amani, who leads outreach, and then that's myself, and I lead the sessions. So just a little note is that we've expanded our team this year, and we plan to keep doing that. So we want to keep expanding, keep growing the team. And if you would be keen, then please get into contact, and you could see your face on one of these slides potentially next year. So yeah, naturally, are there any questions? We're happy to answer any that you may have. And while you think about your questions, I'm just going to put the QR code for the feedback. Would really appreciate if you guys filled this out as well.
I've got one question now.
Yeah.
I think you mentioned the run-through programs. There's initial times that we've got, orthopedics going in. I just want to know that there's run-through programs in orthopedics in Scotland. There's a one that STA posts. It's quite competitive. I don't think there's any MRSA for it. It's only portfolio based. If you're very interested in orthopedics, hopefully they're still running it by the time they're applying, but there is the option for orthopedics in Scotland.
Okay.
They have their website and everything. Have a look at that if you're interested.
Okay.
The other thing is, competition ratios are really high, like you said. That said, to keep an eye on the politics in the country as well. There's talk, of UK graduate prioritisation, which even if you're not a graduate or not, regardless, that we expect it probably will hopefully cut down significantly, maybe more than half by the time people are applying next 2 to 3 years. But we don't know. It's down to West England and politics.
All right, nice. That's all quite reassuring, actually. Yeah. So I'm not sure if you guys heard, but we have a CTF here, and he said that in Scotland there is a run-through program for orthopedics, so trauma and orthopedics. But yeah, so the other thing was that hopefully the competition ratios are getting better. So there's a massive push now. We kind of resisted to talk about the politics of surgical training because we could do a whole other presentation on that alone. But essentially, we're hoping to get more specialist training positions in a couple of years. And then obviously that means more positions. That means lower competition ratios. So fingers crossed for that.
And also prioritization of UK graduates as well, which hopefully should make it easier for us to get into. Exactly. Anything on the chat? Any questions there?
No, there weren't any questions.
Okay. All right. Well, thank you for coming, guys. And hopefully see you at the next one.
Yeah, please do the feedback. We'd really appreciate it. Thanks for coming.
We'll just leave that up there for a minute.